Good morning, Dr. Kinderlehrer. Kristina Bauer with the Texas Lyme Alliance. Thank you so much for meeting with us again today and discussing a few things that are hot topics in the Lyme world.
Nice to see you.
Thank you. So you have a new book that will come out in March, and I wanted to get a little bit of information about that book today. And we also have a discussion circling around your updates on the use of Disulfiram in treating chronic Lyme patients and the use of PTLDS, post-treatment Lyme disease syndrome. So let's start first with asking you, why did you write this book?
Good question. I'm 71 years old. I know I don't look it, but
you don't.
But I am getting on in years. I've been practicing medicine for over 40 years, and I've been blessed to have an excellent training in internal medicine. After finishing my residency, though, I was interested in what was then called holistic medicine. So I became more expert in the fields of nutrition and particularly environmental medicine, which includes food sensitivities and so on. And doing actually a lot of medical detective work in people with chronic issues. And then along came Lyme disease. In the past 20 years, my practice has been limited to seeing people with tick-borne infections, but I felt like I bring a wealth of experience from a lot of different medical arenas that contribute, that are all part and parcel of what we see in people with Lyme, because it's not just a simple infection. It's complicated. In fact, the first name of the book that I thought of was Lyme disease, it's complicated. So I thought, well, while I'm still here, I really want to put all my thoughts down in writing. Up until COVID, I had practitioners sitting in my office regularly, and which I also really enjoy. I enjoy teaching, and I enjoy writing. My mother authored about a dozen books, and I think the writing gene is in my family. So I just wanted to get all of it down in writing, and I learned a lot. I learned a lot by writing this book. It took a lot longer than I thought it would, but that was okay because I really enjoyed the process.
That's wonderful. I didn't know that about your mom. You certainly did get the gene for that. How long did it take you to write?
It took about 4 years to write that book.
Oh my gosh.
Yeah.
And remind me, how many pages?
It came to, my editor says it's 400 pages.
It's big, and I appreciate you sharing that with me ahead of time. It's really outstanding. What was the name of it again, please?
Well, the name of the book now, excuse me, name of the book now is Recovery from Lyme. The subtitle is The Integrated Medicine Guide to Diagnosing and Treating Tick-Borne Illness. I sort of like Lyme disease, it's complicated, nice and simple, right?
Yeah.
I don't think it would have grabbed the long-suffering Lyme disease population as well as recovery from Lyme.
So when is the date that the book will be out?
It's going to be released, I'm told, on March 16th. But it is available for pre-order on Amazon.
Okay. Well, that's wonderful. So we'll definitely encourage people to go check that out and pre-order it. So it's a big success. And I wanted to also mention for all those listeners out there to make sure that they leave reviews for your book, because that's, of course, what helps launch you to the National Bestsellers Authors List, which is a big goal for any kind of advocacy work around Lyme disease. So we all support you in making sure that that happens. Will something like this be on Audible or Kindle or something where people with neurocognitive impairment can be read to, or is that something you've considered?
I assume it will be on Kindle because I know I signed away my rights to that with the publisher. I don't know about Audible. I just don't know the answer to that, Kristina.
Yeah, that's okay. I'm sure once it starts getting out and about that it'll hit the streets on audiobooks, Kindle, and the like, because most books that are popular do end up on there. So that leads me to the next question. We're all itching to hear your update on Disulfiram. We've read your article that came out a couple weeks ago via LymeDisease.org. Thank you for all of the things that you share with patients on updating us on how it's gone. Why do you think your patient group is possibly more sensitive than Dr. Liegner's 3-year clinical study that he published? Is it because you do an integrative approach, so therefore you might get more of a sensitive audience, a population?
Yeah, I actually think that that's a big part of it. A lot of the patients I see have been to other Lyme practitioners. Most all of them have been ill for a long time.
Yeah.
I think that most of my patients would not do particularly well if they were seeing a straight allopathic physician who couldn't help support them on more foundational levels, dealing with their endocrine imbalances and their nutritional issues and so on. Excuse me. So after I saw Ken's numbers, which he nicely, put together and then described at the ILADS conference in September. He described in another conference, and actually now they've been published in a medical journal, Antibiotics,
Yes.
just a month ago or so. I called Ken when I reviewed all his numbers with him, and I asked him, I said, well, do you have people who you have to stop treatment because of Herxheimer reactions? And he said, no, we just slow it down. And his experiences of patients with neuropathy, I'm trying to remember exactly what he said. Okay, he said sometimes they would have to stop treatment, but these were patients already on their so-called maintenance or target dose, not people on lower doses. He did not describe patients with encephalopathy, with brain toxicity from the spread, except to mention a few people with quote unquote emotional reactions, which in fact may have actually been some encephalopathic toxicity from Disulfiram. So I said to Ken, I said, wow, I said, you and I are dealing with different populations of patients. I have patients who on a 16th or less of 16th tablet, that is, or less of Disulfiram, they have severe Herxheimer reactions.
And that's about 15 milligrams, is that correct?
That's correct. I have patients who can't tolerate the smallest doses, and that's it. We don't push it. I have a lot of patients who might tolerate an eighth of a tablet, which is 31.25 milligrams every 3 days, but they can't progress that dose without having significant Herx reactions. I have patients getting neuropathy at low doses, such as 31.25 milligrams every 3 days. And that's despite getting a lot of nutritional support to help protect the nerves, like alpha lipoic acid and zinc and melatonin and so on, which I put all my patients on before they even start the Disulfiram. And Dr. Liegner has not had those issues at those kinds of doses. So the reason I wrote that article for LymeDisease.org that got posted last month, because I wanted to let people know that they shouldn't aspire to necessarily the kinds of numbers that Ken had in his population, which, as you said, they're less sensitive, and I think they have less detoxification issues than my patient population and a whole lot of other people out there. The very interesting thing, though, is that I do have patients who are on low doses who are doing really, really well. And I've gotten to the strategy now that I start on a low dose and slowly progress the dose carefully. And you know the routine. They check in every 2 weeks. We go over what they're taking, et cetera. But if at some point, even at low doses, they're getting very good benefits, they're feeling well, I'll say, okay, we're going to stay right there. We're not going to keep on progressing this dose, because so many times now we've been burned that we progress, everything's going fine, and then one small increment in increasing the dose, and boom, patients have a neurotoxic reaction combined with a Herx reaction. They have to stop it. And here's what's interesting. One of the many things that's interesting, right, is that at that point, they sometimes don't tolerate the disulfiram at doses they used to tolerate at. We can't just go back to the previous dose. We have to cut it way back and then get our feet planted and see, is this okay, and consider increasing the dose. But if they are feeling well, okay, so I'm thinking of a patient. Here's a patient who is very ill for a long time. Among other things, she has a chronic polyneuropathy for which she gets intravenous gamma globulin every 2 or 3 weeks. She has been on a lot of antibiotics, including intravenous antibiotics, which have helped her, but continued to have severe problems with fatigue and cognition, migraine headaches, muscle and joint pains, and so on. And on disulfiram, it was the best she did off of all other antimicrobials. But when we got to somewhere around 125 milligrams a day, she had an encephalopathic issue. She developed a panic disorder. And so we immediately stopped it. But then we did restart it on a slightly lower dose, and she was fine. She actually did very well. And then she said, I think I'm done. She'd been on that lower dose for, I think, definitely months, but maybe as many as 6 months. And then we stopped it, and she went 6 months in remission. And then symptoms started to come back. She'd also been under a lot of stress. And then when we restarted, she's only on about 62.5 milligrams every 3 days. She's doing great. And that's where we're going to leave her. And the long-term strategy, frankly, is not clear. At some point we will stop the medication and see how she does, but she's happy as a lark. And at this dose for her, I'm not worried about neurotoxicity. I have a patient who had previously not been treated. She, of course, has been sick for years. She was herxing significantly on the 1/8 of a tablet, 31.25 milligrams, cut it back to a 1/16 of a tablet. As you said, it's like 15, 16 milligrams. And taking that every 3 days, and she's dramatically better on that dose.
Wow.
If she goes to every 2 days, she herxes, and we bring her back to every 3 days, and then we're doing everything else we can to support her on more foundational levels and help her immune system, her nervous system, her endocrine system, and so on. But the message I want to get out to people is that disulfiram is a breakthrough drug, and I do have patients similar to the ones that Dr. Ligner describes. They've gone into remission and stayed in remission. And even those people, I also have patients who continue to need some other antimicrobial, but they still feel dramatically better than before taking the disulfiram. The disulfiram brought them to a new level.
That's fantastic.
Yeah, it really is fantastic. But it's a dangerous drug, quite frankly, and we have to be very careful. You know, when Dr. Liegner described his first 3 patients, this is over a year and a half ago now. We were so excited because disulfiram had been around since for 70 years. I mean, I think it was approved by the FDA around 1949 for alcoholics. And you think of alcoholics as well, they're not such a healthy population. And guess what? They didn't have very many side effects from this drug. And yes, side effects were reported, of course, but no big case series, you know, not tons of neuropathy and encephalopathy and so on. So we had this false sense of security of, wow, here's a drug, it's been tested, we know it's pretty safe. We know it has a pretty short list of side effects and so on. It turns out just that Lyme patients do not have the same metabolism as alcoholics. And I think that's kind of obvious because how many Lyme patients can drink a beer? I mean, let alone 3 6-packs a night. You know, if I take a sip of alcohol, I can feel it. You know, and most of my patients can't tolerate any alcohol. So, you know, I think that says a lot in terms of the differences in our detox capacities, and that alcoholics, at least on some level, are detoxing quite well until they reach end stage cirrhosis, of course. So, you know, I'm trying to put on the brakes a little bit, saying this is still a drug that's worth trying, particularly people with Lyme and Babesia. Another difference with my patients is between my patients and Dr. Liegner's is that it's unclear how many of his had co-infections. You know, he was able to document that about 40% had co-infections, but he said, you know, this is, if I diagnose clinically, I know it would be more. He was diagnosing on the basis of the serological testing.
Right.
And, you know, and I, of course, do the serological test too, but the fact is that all of my patients have co-infections. And in fact, the majority have both Babesia and Bartonella, and occasionally, you know, mycoplasma and anaplasma and so on. So, what can I say? You know, these people, as you know, with multiple infections, they're sicker, and they're more sensitive, and it's trickier to treat them.
That brings me to my own perspective of why disulfiram is more, you know, having more reactions with Lyme patients than alcoholics, is because of the level of inflammation and histamine in a patient. Do you concur that you think that is the leading cause of the differing reactions between alcoholics and Lyme patients?
I can't say if that's the leading cause, to be honest. I think there are multiple causes. Like I said, I think Lyme patients have more detoxification issues and are going to be more sensitive to the alcohol and acetaldehyde than an alcoholic.
Right.
But it definitely is an issue, and there is data in the literature that suggests that disulfiram can trigger mast cell degranulation. And I have seen patients in whom their mast cell issues have gotten much worse. After being on disulfiram, they've become much more sensitive in general. It's really sad to see that. You know, it's always sad to see a patient react to a treatment, especially when that reaction doesn't go away. when we stop the treatment. So it is something to be aware of, that we can trigger these mast cell issues. We, as you suggested, Lyme patients are really prone to mast cell issues. We do see it a lot. And perhaps we should be treating that in some sort of preventative way when we put people on disulfiram, and I put people on so many supplements to support their liver and to help with detoxification otherwise, as well as to protect their brain and nervous system. That,
right.
But perhaps we should be adding, say, something like quercetin and so on to help decrease mast cell degranulation. Maybe that should be part of a protocol.
We use H1 blocker and H2 blocker, which would be loratadine or Claritin, and then Pepcid AC Max twice a day with vitamin C and quercetin. Is that what you see working well for this patient group we're discussing now with some mast cell disorder?
Well, it's a good question. This issue is like so many other issues when we're dealing with Lyme patients, which is that it's a very heterogeneous population.
Yeah.
And the agents that you're taking, you and your family are taking, are in fact agents that I recommend routinely. And there are others, including chromalin, which is gastrochrome, and ketotofin, and Singulair.
Right.
And you never know which is going to help these patients, to be honest.
Right.
It's just always so diverse. But I will say, consistent with what your remarks earlier, Kristina, that food sensitivities are a big issue.
I was thinking the same thing. Yeah.
And I devote a lot of time in the book, a lot of space in the book to this. But, in the old days when I finished my internal medicine residency and did not want to practice internal medicine, which is really practicing end stage disease where you don't cure anybody, right? I hung up a shingle that said nutrition and preventative medicine. And I started seeing people with these long histories in going to major medical centers in Boston, because I lived outside Boston, where they'd been worked up for their chronic inflammatory bowel disease and their chronic migraines and chronic this and chronic that. And that's when I turned to environmental medicine. And a doctor who was a pioneer in that field, Dr. Jonathan Wright, he had said, if there are 3 or more unexplained symptoms, think food sensitivities. So I started putting people on elimination challenge diets back then. And lo and behold, I was curing people with these longstanding chronic issues who had, 2 feet of charts at Mass General Hospital because no one could figure out why they had awful canker sores that they were getting injected with steroids and these chronic bowel diseases and chronic migraines, et cetera, et cetera. I mean, it was quite the revelation. But, it's a sad commentary on what's been happening, which is back then, it was very easy to put people on an elimination diet. There were about a half dozen foods that if someone was sensitive to, they'd be sensitive to 1 or more of those foods: milk, corn, eggs, wheat, citrus, sugar, caffeine, food coloring and additives, might be the top half dozen. So there'd be gluten and soy and peanuts, but which, as you know, are not a nut, right? They're actually a legume. But also beef and pork, they might be in the second tier. But it was very easy to put someone on an elimination diet. You give them lamb and rice and greens and fish. I mean, it was very, very simple. Nowadays, it's gone nuts, and it's emblematic of what we've seen in terms of, you'll excuse this word, perturbations in our immune system. That is, as we have done a decent job up until this pandemic of really mitigating some of the serious infectious diseases like malaria and tuberculosis, they're not gone whatsoever, although in Western countries, they are minimal to gone. what we've seen is more and more autoimmune illnesses and other chronic illnesses, and count in multiple food sensitivities where now people are reacting to lettuce and avocado and rice. We never saw that a generation ago or 2 generations ago. And then, of course, as sensitivities increase, we also see a lot more people with multiple chemical sensitivity disorder. Back when I was treating people with this MCAS diagnosis, it was considered quackery by the allergists and immunologists. But now, my neighbor is an executive director of the huge Colorado Allergy and Immunology. They have 12 different offices around the city. And there's a sign on their door that says, "Don't come in if you're wearing a fragrance." I mean, now it's generally accepted, even though we still don't understand the pathogenesis of like, how is it that people react to this stuff? What's happening on a biological level? But we're starting to see, and I suspect you hear about this, and that's electromagnetic field sensitivity.
Yes, sir.
And
it's a big deal.
Think in another generation, it's going to be like MCS is now, or food sensitivities were a generation or 2 ago. And we might not understand the mechanism. I mean, we know it's going to affect electrical pathways in our body, but more specifically, we are seeing more patients who are sensitive to EMS, that they can't be in a house with the Wi-Fi turned on. They can't hold a cell phone to their heads. And the 5G is going to make it a lot worse. So it's very sad, what we're seeing here. And I expect we're just going to see an increase in this evolution of immune disorders in association with it.
So that's one of the big things that I do as an advocate, is encourage people out there to research and educate themselves on the potential dangers of these types of infractions in our society, and write your legislators about your concerns, and ask for those studies, because when we start being loud in the squeaky wheel, we can vote them out if they don't act. So that's a big part of it. I don't want to get off the disulfiram issue just yet, because you mentioned Bartonella. 2-part question. What do you use for Bartonella if Bartonella symptoms flare while people are on disulfiram? And then I want to visit about some eye issues after that.
Okay, so early on, it became apparent to me that disulfiram not only hits Lyme and Babesia, but does hit Bartonella. We don't know how well it hits Bartonella. The people who've been in sustained remissions are mainly people who have Lyme and Babesia. And the fact is that most of my patients with Bartonella also have Lyme and Babesia. So, and already if there's 3 microbes involved, we know it's going to be harder to treat. But if people have a Bartonella flare, when we're progressing the dose of disulfiram, I treat it the way I would treat any Herx response, which is that I might cut back the dose of disulfiram and give them any number of agents, from alkalinization and more toxin binders and CBD and anti-inflammatories and so on, to decrease any Herxheimer reaction. So it could be that Bartonella infection is going to be a limiting factor in how much one can progress the dose of disulfiram. There's no question that people can have Babesia Herxes, Bartonella Herxes, Lyme Herxes when we progress the dose, and we just have to, go slower and cut the dose back and be willing to just stay at a lower dose if we're getting good results. That's been what I'm doing most recently, like we've discussed. In terms of Bartonella sensitivity, let's call it that.
Okay.
In my experience, Bartonella causes more inflammation than any of the other infections. Perhaps mycoplasma comes in close to that in some people, but Bartonella causes a list of like 15 different autoimmune issues in the body that we know about. And it's not like Bartonella is high on the consider list for most rheumatologic and infectious disease doctors. It's not. It's very difficult to do cultures. Galaxy Lab does a culture, but the antibody tests that are done are not great. Most of the diagnosis that I do on Bartonella is clinical, and it's not that hard to diagnose. If patients have a disproportionate amount of neurological symptoms to musculoskeletal symptoms, I immediately think Bartonella. If they have severe neuropsychiatric symptoms, I immediately think of Bartonella. It also can cause eye problems like you described, but the other pathogens can also cause some of those eye problems.
Yeah.
There's no question. And Disulfiram can cause optic neuritis. So that's something we need to be aware of as well. And then there's gastrointestinal issues that we see with Bartonella, and there's dermatologic issues we see with Bartonella.
Yeah.
And then there are the Bartonella stria, which look like stretch marks, but they're really in the wrong planes of stretch marks. And those are virtually diagnostic of Bartonella. There was a paper released by Ed Breitschwert, whom you may know about. He's a veterinarian, but is considered, I think, the national expert on Bartonella, has done a lot of studies in humans on Bartonella as well as animals. And just had a study last month released where they looked at about 24 patients who had the onset of neuropsychiatric symptoms and the simultaneous onset of these stria or another rash. But they were actually in another study, they actually biopsied the stria and saw Bartonella in them. So Bartonella can cause neovascularization, new blood vessel formation and so on. And that's what we're seeing in the skin with a lot of inflammation. Bottom line is it can cause amazing amount of inflammation. And what that means is in some patients, the lowest doses of anything we give them for Bartonella cause a flare. And sometimes we just have to be patient in terms of treating everything else and seeing if the body's immune system, becomes less reactive. But we can use very low doses of some of the extracts. We have Beyond Balance makes an MC bar 1, and Research Nutritionals makes BLT. I would probably in that particular situation not use ABART, which is more by Byron White, which is much more powerful, I think, and much more likely to cause Herxheimer reactions. But also Japanese knotweed actually has significant Bartonella activity, and the nice thing about that also is that you can get that in an extract. Japanese knotweed, by the way, is resveratrol, which is famous in red wine and so on. And anyway, when it's basically hit or miss, the standard antibiotics. I should mention I have patients who don't tolerate any of the so-called natural antimicrobials, and but do well on standard antibiotics. So Bactrim, which is sulfamethoxazole trimethoprim, a standard sulfa drug that's used a lot for urinary tract infections, but it's also used for sinus infections. It's used to treat methicillin-resistant staph infections. It's out there a lot. It's a decent drug for Bartonella, and rifampin, an anti-tuberculous drug, is a decent drug. The very best drug for Bartonella are the fluoroquinolones like Cipro and Levaquin, but they also can cause really serious
Yeah.
toxicity, and I'm very, very careful about using those drugs, only as really a last-ditch effort. And as you probably know, they can cause a chronic tendonitis.
Yeah, it's
Chronic
dangerous to use them.
it goes, yeah, and the Lyme population is, of course, going to have more reactions than the general population, because these drugs are used all the time.
Yeah.
For pneumonia, bronchitis, sinusitis, urinary infections, and so on. They're prescribed all the time, and I think the family docs are not seeing that much in the way of toxicity or serious side effects. Of course, those are relatively short-term treatments. Some men with prostatitis sometimes are put on long-term treatment. And we're talking with Bartonella, we're talking long-term treatment.
Yeah.
You know, even infectious disease doctors have said that they might use triple antibiotics to treat Bartonella, and they still don't think they're getting rid of it. So I don't know if we ever get rid of it. The good news is there are lots of people with Bartonella who are fine. That is, their systems are not reacting to it. And I just want to emphasize that to the listeners. The problem isn't the bug. The problem is our reaction to the bug. That it seems to have the potential to trigger such severe systemic inflammation. And so we really got to work on that component, on the inflammation component. As you've probably heard of LDI, which is the low dose treatment. It's like an allergy treatment, which gives the idea to the immune system of, don't react to this, just leave it there. And
the desensitization to the pathogen.
Yeah, and the correct word would probably be neutralization. Desensitization usually refers to the high dose immunotherapy, and this is ridiculously low dose. I mean, I can't tell you how low these doses go.
We've been on them for 3 years with my family. Homeopathy and low dose immunotherapy has been our go-to for all 5 of us, and we've all done very well. Very little antibiotics in my house ever.
That's great. That's really great.
Yeah, it's helped.
But I can tell you, I've had patients with Bartonella where we've given the lowest dose imaginable and just put 1 drop on their skin, and they have a Herxheimer reaction that lasts a month. I mean, that's how inflammatory this can be. I also think Bartonella is a common cause of PANDAS in my patients, pediatric autoimmune neuropsychiatric disorder, these kids who develop OCD, anxiety disorders, depression, other mood and behavioral disorders, eating disorders. I think that Bartonella is a significant issue. I had a patient who was diagnosed with anorexia nervosa. The full presentation, she felt that she was overweight, although she wasn't overweight at all. And ironically, she thought these Bartonella stria were stretch marks. And we treated her with IV antibiotics for Lyme and Bartonella, and she no longer has anorexia nervosa. So
wow, that's amazing.
Yeah.
So that brings me to mentioning for the audience that we're going to be doing 2 more interviews coming up. The next one will be on PANDAS. Mm-hmm. And as you mentioned, we have 3 out of 5 of us here in our home that are PANDAS. So I'm very interested in learning more of what you have to say on that. And then the third one we'll be doing on eating disorders and Lyme disease. So I think these are really big issues for people that they'll be very interested in learning about how you're seeing these things and what you're doing to treat them. So just giving people some hope that more information from the great Dr. Kinderlehrer is coming. And of course, the book will be wonderful to have in their hands to get in a little more detail.